to invite you into my world of uncertainty. Now, whether you know it or not, you guys are already enmeshed in a world of uncertainty. It's just that perhaps we don't think about it so much. I used to read a lot of science fiction, and when I was a teenager, I read Dune. Many of you will have recognised Sting there in Dune, and it was a shocking movie actually, but that's beside the point. But the book was quite good, and I just started with a quote from Frank Herbert, who wrote Dune, and thank you for someone suggesting I have a Queenslandian dress sense. He wrote about the generalists, and this quote is that specialists soon lead you quickly into chaos. The Mentat generalist, which is the generalist in the Dune series, the Mentat generalist, on the other hand, should bring decision making a healthy common sense. The expert looks backwards. He looks into the narrow standards of his own specialty, surgery, case in point. The generalist looks outwards. He looks for living principles, that's us, guys, knowing full well that such principles change. There can be no permanent catalogue of such change. You must look at it with as few preconceptions as possible. Wise words from Dune, had nothing to do with medical generalism, but I think apply to us. So I thought we'd start with a bit of a scenario to wake you all up and give you a chance to vote. So Shelley, if you could bring, well, I'll just describe the scenario. So basically, it's just a male in his 50s, not a special male by any means, just your typical fella. He's got diabetes, he's on multiple medications, high blood pressure, he's probably got hyperlipidemia and a few other things, perhaps a vitamin D deficiency, so he's on vitamin D, testosterone deficiency, choose your own favourite deficiency, and possibly even an antibiotic deficiency, judging on this question. But so there are these two scenarios, and the question is which of the two is it more important that your registrar makes the best decision about the intervention? So one is he comes in with a boil, and it's one of those juicy boils, you just can't, you take one look at it and you just want to poke something into it. And he'd been picking a scab a few days earlier and got this boil, and there's a bit of surrounding redness, perhaps some early cellulitis, and a couple of other small boils developing. He's not sick or anything, but he's got that and he's a diabetic. The second scenario, and we're coming back to these two, so we'll go through it, is he's got a sore throat and a sore right ear, and your registrar has a look in the ears, and they're both a little bit red, a bit suffused. He's got a temp of 37.9, so mild fever. He's not all that unwell, but he's sick enough to have taken the day off work to come and see you, and he's got a job interview in 3 days' time, he tells the registrar. So the question here is, and many people are voting, so fire away on your little buttons. In which of these ones do you have to make sure your registrar gets it right? Because if they mess it up, you can get into trouble. So this is sort of looking for red flaggy things, or looking for just safe practice. And we can see from the poll that we're running at about 85% for scenario one. With all these things, there's no right or wrong answer, but certainly I would be among the 85%. I would think that the problem with the boil is he's got diabetes. If your registrar for some reason doesn't do something about it, doesn't poke it or give it antibiotics or whatever the relevant treatment is, then the guy could get quite sick. The second one, look, of course, anything could happen, but it's very common. And, the decision between perhaps giving an antibiotic or not an antibiotic probably won't mean as much to that fella as it would in scenario one. That'd be my thinking. Someone said it is a shocking movie, but great book. I agree. We're back to June there. Anyway, so the second question about the same fella, same scenarios, is in which of these two scenarios is it harder to teach your GP registrar how to handle it and what to do? So this is a teaching question, not a clinician question. So it's not you doing something to this fella, it's you teaching a registrar how to handle this sort of consultation. So I'll just give a little while for you to fire up the numbers there. A generalist is an old American term, says Brendan Kay. There you go. Goodness me, have we got no rogue voters at all? Oh, thank God there's one there. Someone reckons it's hard to teach about the boil, perhaps how to stab the knife in, or I guess you could argue that there's if it was a solitary small boil, maybe the person might not need antibiotics. Although, as I painted it there, they probably do, I suspect. There we go. So we're really running at about the opposite, so about 85% the other way. And again, I would, being a majority voter, I would go with the majority there. And someone's couple have pointed out that, yeah, I am, a lot of registrars are non-proceduralist and afraid to poke. I love poking things. I hope sincerely everyone on this webinar does as well. Yeah, I think I agree. Get your registrars to get their hands dirty, and the other, there's actually good evidence. This is a total aside, that the lifelong pattern of registrars doing interventions, things like injecting shoulders and all that sort of stuff, and a lot of other things like home visits and things, all depend very much on their first job. So I think if we get registrars doing more and maybe extend ourselves, and that's a good thing. No guts, no glory. Oh, this is great. Love a good poke. Helen M, you and I can just poke each other. All right. So the point there being, the reflection on that being that it's the uncertainty, I think, is something which is difficult, and it's also hard to teach. We get actually very good at it, better than we think. But for a registrar coming in, it's a mystery to them, and they probably have already been taught in their years of medicine and their first few years at hospital what to do with an abscess. They've probably done an ED term and stuff like that, and so for them, I suspect most of that isn't all that difficult. But it's the uncertainty of diagnosis which is particularly difficult to teach them, and I think as such we have to spend a bit of dedicated time raising the topic with them and teaching, which is what this is all about. Okie doke. Laudable pus needed. Is that pus which you admire? I'm not sure what the word laudable adds there, but it's a laudable thing. Pus is needed. Never let pus see the light of day, I think I was taught. I think there's another one about pus getting out eventually. It's pus like love will always find a way. All right, back to the scenario. So you have a GP registrar called Sally, lovely Sally, and you're sitting in with her and you're doing a case with her, and so you're not saying much during it, you're just observing her. And so the father comes in with a 6-year-old son called Zach, and the father's come straight from school. The teacher said Zach was looking a bit crook and sleepy at school. Father drove to Zach, picked him up, and luckily found an appointment on the same day with Sally, and she's in your practice. So Sally, you watch Sally take the history. Laudable pus. Oh my God, you guys can all read that. Very good. Thanks, Jan H, about the 19th century use of laudable pus. Very good. So Sally takes a good history and she, decent history. I'm not going to go through it, but, she just covers the red flags and things, so you're not that worried about the history. She does an examination. Zach has a temp of 38.7. He's not looking awful. He's one of those kids that sort of, they're pretty brave with it, with that temperature. They're sort of glowing a bit, and they're not exactly running around playing with the toys, but he's not awfully dehydrated. And Sally does an examination, ENT, respiratory. Maybe she even does too good at the examination. She starts testing for percussing and vocal fremitus, whatever the hell that is. If any of you remember that sort of stuff, all the stuff you never actually do, but don't tell the registrars. And a good abdo exam and a skin examination. There's nothing all that much on those things. She doesn't find anything much. And we've got people eating their dinner and not worrying about the pus. Well, don't eat your dinner. So go and grab a glass of wine instead. That's my advice. 4-ward test Sally does, shows a trace of blood and a trace of protein, and Sally says to Dad a couple of things, gives him the scenario and a couple of phrases she uses. Zach's fever is confusing, she says to the dad, certainly is to Sally, and she also says it could be a urine infection, which often calls what we call a fever of unknown origin. At least she hasn't used the word pyrexia, I guess, so give her points for that. And she does some tests. So she orders a blood test on poor little Zach, an FBE, CRP, ESR, and sends the urine off for a micro and culture. And her sort of end of the consultation follow-up is reception will phone when the tests are back, and we'll get you to come in again. So what I do want to do now, this is probably a time I do want you to use the little text boxes there rather than the voting thing, and just sort of give me, I'm not really looking for the answer to this consultation, because I'm not really going to give you any more information, and so we don't know the answer. But the point is, it's meant to be a bit, it could go either way. My point is, what are you going to be saying to Sally? How are you going to turn this into a teaching moment? Luckily, she's got no one coming next, so you've got 10 minutes to ask her a bit about this consultation, ask her a few questions, maybe prod her, don't poke her. Not allowed to poke your registrar. So how long has he been sick for? The teacher said he was a bit crook, so Dad sent him off to school in the morning. So he's been sick for a couple of hours, I guess, a few hours. That's not sort of, you're asking me the questions, that's fine. Sally did sort of check out that. So, so I think, a good one, I think, from David, who says, how confident are we in your follow-up plan? So I think clearly, it's skipping a bit towards the end, but the follow-up plan, we won't go into the pros and cons of it, but, most of us would see, well, if the kid really is sick, is it possible that follow-up plan wouldn't be ideal, because they're sort of sitting there waiting for us to phone. Some of the other things are asking for extra history, which I think is good. So we would perhaps ask Sally, were there some things in the history which you could have asked and maybe didn't ask? We've got people mentioning safety netting around fever management. So you could say, you could ask one of those what if questions. What if he didn't have a fever and looked fine? Or what if his fever was 40 and he looked moribund? So you can always use those sort of teaching moments. There's how significant, says Ashley, are the 4-ward test findings, and I think that's a very good one. There's a whole thing, you could run a whole tutor on that alone almost. You could say, why did you do the 4-ward test? I think it's actually perfectly reasonable she did, but why did you do it? Why did you choose this test and not another test? What does trace blood and trace protein mean in a kid? Is it significant? And what do we do about it? Do we follow it up? What would you do if the MNC comes back, with a possible skin contaminant or something? What do you do there? Is this a really sick child? We're sort of saying it's not really. If it's a really sick child, it's easier. You could ask the patient, Sally, what would you do with a really sick child? So Brendan says would not have done bloods, and I think that's certainly a quite legitimate observation. So how would you say that to Sally, Brendan? I'm sure you'd be very nice to Sally and say, what are the pros and cons of ordering bloods in this case? And then Helen M is talking about missing things, and we also, what might you miss? What are you worried about that you might be missing that you ordered these blood tests? The other thing would be if often registrars come in saying things like, I wanted to rule out something, and you could sort of sometimes reapproach it and say, well, it could technically, the kid's been sick for 3 hours and has a fever and nothing else, could technically be one of 2,000 infections, including meningitis and deadly infections. So the point is, is there such a thing as ruling out? Can you rule out that this kid doesn't have a deadly meningococcus right now, sort of thing? So the whole concept of ruling out, which in hospitals I think is a very much taught concept. You get them in, you've got a ED, they're sick, you've got to rule out a whole bunch of things, then you can send them home. In general practice, what is the course of this illness after 2 hours? Would you expect a kid who's got a cold for 2 hours to always have red ears or a sore throat or visible glands up or something like that? All those things. I won't. So look, there's lots of other good suggestions there. You can read them, but we'll move on. But so the point there, I guess, and this particular case study is actually in the resources box, which Glenn or Shelley will tell you about afterwards, but there's a little folder down the right-hand side. And, oh, goodness me, there's Shelley, I think, doing a little arrow there down to the folder on the right-hand side. Thank you, Shelley. And that in that is the whole resource for this thing, which I helped write, and that case is there. So, and again, we don't have answers in the case, but we have the sorts of questions you'd ask your registrar. All right. The other main thing I was just going to say was, the history is comprehensive, which is good. Sally, was she comfortable with the situation at home? In other words, does Dad have the car and it's, Dad is going to be looking after the kid, or is he about to go off camping or go off to his mum's place or something like that? So just sort of trying to get that more general social history as it may impact on adherence to treatment or getting the tests or coming back if he gets sicker. Okay. No one can be confident in reassuring this patient they don't have sepsis. Of course, you can't be confident in it. However, you have to reassure to some extent, or else you'll really end up telling every single sick child who comes in your door, a child with a fever, that they could have sepsis. But I guess that's the whole point of the safety netting. Let me move on, just because I can. This fellow, Daniel Kahneman, was a Nobel laureate, actually. He was a psychologist, I think, and he wasn't a psychologist, he was an economist, and he won a Nobel Prize for some of his work, and I just wanted to quote from his book, because I think it was quite... so he talks about the rise of the expert, as opposed to, again, the generalist. So experts who acknowledge the full extent of their ignorance, and that's someone like me, for example. Actually, I don't know about the expert, but I certainly acknowledge my ignorance, may expect to be replaced, unfortunately, by more confident competitors who are better able to gain the trust of clients. And he'd be talking just as much about real estate agents or something, or stockbrokers, as doctors. An unbiased appreciation of uncertainty, which is what we're getting today, is a cornerstone of rationality. So we're all trying to be rational doctors, and we accept there's always going to be uncertainty, but it is not what people and organisations want. And I think that, is one of the struggles we have as GPs generally, is to try to get people to understand that. And of course, there's, and ditto media headlines and politicians and lawyers and things when someone misses something, as if there should never be any uncertainty. And that's just a bit of banter between Shelley and someone who can't get on. All right. Let me talk to you about the linear consultation, the non-linear consultation, which is a concept I sort of came up with a couple of years ago, and there's a link again in that folder there, down on the right, to my brilliant article. But yeah, so the linear consultation to me is one where it could be a nasty medical thing, but essentially the arrows all point one to the other. So your fellow with the diabetic with the pus on his leg is a linear consultation. Someone you know, a sports person who's otherwise well carried into emergency department with a broken leg is a severe injury, and it's very important people know what to do, but it's fairly linear, basically. You know, there's a fairly well-trodden signposts of, you know, pain relief, x-ray, and move him on to somewhere inhabited by an orthopedic surgeon. So although it's very important people get it right, it's not that hard to teach, okay? And here's my joke, because I get to wear my funny shirt and I'm the only one with the microphone, I get to tell jokes. Doctor, I get terrible pain when I press my finger here and over here too. And even when I press lightly both here and over here, what on earth could be wrong with me? You have a broken finger. I'm assuming you're all laughing. Unfortunately, your mics are off, so I'll just take your laughter as given. So, ha-ha, thank you, the ha-has. Now, the non-linear consultations, so these are the ones, I mean, the previous slide had these lovely wires, which, you know, they start in one spot, and even though there's 50 different pathways there, you know, they end up in another spot if A go there, if B go there. So a nice little sort of linear algorithm. The non-linear consultation, this is more, if I was to show you my desk, in fact, with the camera, I won't do it, but it looks a bit like this, and it's sort of more my life. Now, the non-linear consultation, yeah, so this is an example of one, which is that, so the person walks in with a situation and says, I have a headache, you know, I get pain in my head. So the next question you ask, or the registrar asks, or a medical student asks, or a male doctor asks, or a female doctor asks, you know, probably most of us would ask some sort of open question next, you know, tell me a bit about the pain or whatever. And then after that, it starts to branch out. There's all these arrows that can go anywhere. You could end up asking about, you know, what have they done for the pain or the pain relief, asking about, you know, the heads, HEADDSS, if they're a teenager or whatever. So there's lots and lots of different ways that consultation could run. Now, I'm just, and each of those then can branch off into other ways. And in some ways, there's no actual correct way to finish off this consultation. At some point, and we all know this, and we'll teach our registrars, you've got to ask about red flags and rule out nasty things, okay? But that's all very fine for the nasty things. But in fact, the majority of people who come in and you figure within a few minutes, it sounds like sort of stress, tension, headache, and you've done enough to rule out nasty things, it's not as if you're there. You then have to decide, what are we going to do? And I think that is where the uncertainty comes to the registrar. They've been taught, rule out red flags, and then if it's not this, that's fine. It's sort of like chest pain and casualty. Okay, if it's not heart or lung, that's fine, tick, back to the GP. The problem is now they are the GP. So I just ask you to type in a few things as to possible. Now, at the end of all these arrows, everyone's going to end up at a different part of the end of series of 10 arrows. In your lifetime or an interesting patient or recently, what is a possible end thing you might end up discussing as part of your management plan or something for this patient? Again, there's not only is there no right answer, there's literally 1,000 answers. I mean, I can imagine you might end up discussing, you know, the safety of taking walks around your neighbourhood, because you start talking about exercise, and then they said, oh, it's a bit, you know, dangerous after dark, and so you maybe talk about taking your dog. So we've got relaxation strategies, lifestyle changes, massage. So you could end up talking about where can you get a value for money massage, because they haven't got much money, can they afford it? Depression and stress you would ask about, and if appropriate, you'd get into that whole thing. Sinusitis, maybe they've got sinusitis. Has it happened before? What has helped? Domestic violence. It might not be a tension headache. That is true. Work. You might, once you start asking about work, of course, all of these little branches, again, can split in. I mean, it may be that the first question you ask about work, the person starts crying and telling you what an awful boss there is. And in that case, it's very appropriate to spend the last 5 minutes of the consultation talking about the boss or the workplace scenario or all those sorts of things. So again, it's very patient delivered, I guess. Someone's called me a legend. My first, thank you, Brendan K. We can perhaps highlight that later. Posture, oh my God, I'm leaning forward on my chair too. Anyway, so my point is there's lots of different ways that could end. All right, thank you. So that was where the management plan ended up. My next question is, how, given there's 1,000 correct answers, how can we teach our registrar where it should end up if no single endpoint is correct? Some registrars, you know, are mature before their time, and some registrars, you know, are mature before their time and will quickly cotton onto this thing. But, you know, if you've had enough registrars, I think I've probably had 20 in my time or more, yeah, you will get the odd one who does want you to give them the sort of answer, oh, okay, so attention, how do you treat that, or what should I do about that? And to me, you know, that's fine. You can look up Murtagh and get a couple of medications that might work, or relaxation or exercise or something. But again, there's not actually a correct way of if you haven't seen the patient and the registrar says, how do I treat this patient? You can't just say, I tell them about exercise or something. You have, without knowing heaps about the patient. So as Andrew M says, thank you, Andrew M, there is no right answer. How do we teach them? Do we teach them nothing? No. So we have do no harm. First, do no harm. I think that's very important, and that, you know, I mean, others have heard me rabbit on a bit about perhaps our overuse of pharmaceuticals, and that's certainly, you know, one of the things about doing no harm. And then the diagnostic structure. I like that sort of idea. And we've got the Anna T's got the Murtagh sort of thing, exclude the serious things not to be missed, but we've sort of already done that. So yeah, the diagnostic structure and follow-up. I think this is an opportunity where we teach the nuts and bolts of how to deal with uncertainty. When the registrar is uncertain, they're not going to get certainty from us, and we don't need certainty to deal with this patient. Because if you get 20 patients in a row, you know, in the course of a month or 2 months, which might well happen, we don't have to have certainty before we can deal. There's no point in saying, oh, we just keep doing stuff until we absolutely know what's going on. We don't need that. All right, what else we got? Yeah, you need to make sure the patient's expectation is still filled, and I think that's a theme we'll come back to a bit later on. So it's clear the theme we're teasing out here in your answers, I think, is that the more uncertain things are, or the more, you know, scenarios set up for uncertainty, the more we have to be listening to the patient. It's where the communication skills come in. It's where the patient-centered stuff comes in. Patient-centeredness doesn't matter all that much if the guy has a broken leg and he's, you know, going to need an orthopedic surgeon to deal with it. But it matters a whole lot if someone has a stress headache. All right, and certainly talk about engaging in therapeutic relationship. That's the therapeutic relationship. I think it's worth a quick mention because it's the old thing of, and certainly I work in Aboriginal health, and it's absolutely crucial there that it really your management of something like that. Probably it's more important that you just get on well with the patient and they think that at the end of it, the person listened to me and tried to help me, and yes, I'll come back. That's probably more important than any knowledge of specifically, oh, well, maybe I'll choose an NSAID or maybe I'll choose a, you know, some other particular intervention. So in the long run, you don't fix stuff like this in one single consultation and they all go away. The whole point is the engagement. I will move on. I've been accused in the past of talking too much. The consultation should be a journey, not a destination. I'm writing that one down, Andrew. That goes in my next article for sure. Beautiful. All right. So there's this brilliant quote here. The essence of general practice is having no idea what next medical issue will be when the patient walks in the door. The essence of dealing with uncertainty is still having no idea when they walk out of it. Genius. that guy. That was one of my other, sorry, it sounds like I'm just plugging my articles, but of course when you're preparing a webinar, I zip back through my old stuff and cut and paste. Another sort of bad dad joke, but you know, quite a poignant one this time. Oh yeah, actually that's right, I'm going to spend, I decided you're a captive audience, I'm going to spend 2 minutes reading out a tiny bit of that article. So this was an article I called Dealing with Uncertainty, I wrote a few years ago. So this is discussing me giving this awful tute, very poorly done, because I mock myself, tute to a registrar about dealing with uncertainty. So this was my teaching method. So this is the phrase I started with, telling my registrar that. As an inherent skeptic, I explained, my diagnoses, while brilliant, do tend towards vague motherhood statements. Thus, when a patient complains of painful lower back, my eventual diagnosis after a thorough history and examination is low back pain. My registrar was nodding sympathetically and retreating towards the door. But I expounded, who am I to be certain whether they have subluxation, disc degeneration, or negative chi? I was enthusing now. And as for assuming my intervention of massage or gabapentin directly causes the pain's eventual resolution, well, call me Dr. Doubt. Post hoc, I boomed as sagely as I could, does not always imply propter hoc. My gratuitous Latin further unnerved my registrar, so she quickly and somewhat unimaginatively shifted the focus back to her own learning needs. But uncertainty makes a GP's job so difficult, she said. Was I witnessing a watershed educational moment? I mounted my high horse to better the view. And that, I gloated, is why I rose to my calling and rejected all offers of careers where I would be forced to deal with certainty. I always finish tutes with either a quote or a misquote, according to need. Said Bertrand Russell, fools and surgeons are always so certain of themselves, yet wiser people so full of doubts. Finally, no doubt wisely, I let her out the door. Thank you. All right, enough frivolity. So, how do we, oh, thanks, Gundi. I'm adding up all the ones who say, thank you, that was very nice at the end of those silly things I read out. How do we, this is the last couple of slides are where all our meat is. So, and again, all these topics are listed on the document in the folder, which is all about how you can teach your registrar about uncertainty, how to run a 1-hour tute or whatever you've got on dealing with uncertainty. So you don't have to write these down. I think they're all in the document folder. I've just got their headings, which we came up with when we were writing the resource, and I'll just, we'll talk about them a little each. So first is recognising a registrar who's struggling with uncertainty and some of the telltale signs. Excessively long consultations. So, I mean, you know, all registrars start slow, very appropriate. If they're still, 3 months, 6 months into their rotation, going very slow, you just wonder, maybe they're just very thorough. But it does, it's one of those things where perhaps they're very afraid of missing something. And the problem with being super afraid of missing something is that you, in fact, don't get enough stuff. You spend too much time on stuff, which really, if you said, like that kid who'd had the temperature for 3 hours, look, I'm not entirely sure what's going on. It could even be a cold. How about we book you in tomorrow morning, come back in. If you get sick overnight, go to ED, come back in tomorrow. I'll have another look at the throat and maybe you'll have a sore throat. So you've got to, the registrars have to learn to cut off these consultations and accept that they're not certain. They don't have to be certain at that moment in time and come back. Excessively long patient notes and history, of course, as we get older, we all get shorter, which is terrible. And it's probably a good thing they start writing more notes than we do. But if they keep writing reams of them, that can be an issue. Irrational test ordering and irrational prescribing. So again, I won't go on about them because I talk about them in at other times, and Simon Morgan talks about them as well. But essentially they're just throwing tests out there all the time, or just every time they think they might have a diagnosis, they're coming up with a pharmaceutical treatment for it, it may be because they're scared of sort of saying, we've got to wait and see, or let's see how this goes. Poor second career in theatre, goodness me. Poor clinical reasoning, which and we talk about cognitive biases, and there's another episode right there, but they have to, you maybe go back to basics and get them to do a logical step through the process of diagnosing something, even if the diagnosis ends up with just a reasonable differential diagnosis. Sometimes they panic and don't do that. Anxiety, very common, very common. Of course, of any group of 100 of you guys on the thing, of course, some of us will have anxiety as well. Something's highlighted in red. Registrars, says Vicky M, also need to recognise the level of comfort with uncertainty, as well as each individual patient's level of comfort with uncertainty. So very true. We each have our own level of uncertainty, and the patient does too. And again, a highly anxious patient, you may have a different threshold. It's probably quite appropriate to have a different threshold for someone coming back, or not sending them to hospital, or whatever the threshold is. It does depend both on the doctor and the patient. Anxiety, 25% of GPs, said Linda T. Perhaps we will have a vote on that before we're done, Linda T, but not now. So all these things, so they're hints that the registrar might be. The other thing is knocking on the door the whole time. Lovely, love it when they knock on the door. It's a privilege of being a supervisor, even though, let's face it, it's a bit of a pain when you're behind, but it is a privilege. I always think of it, you get to see the most interesting, for 3 minutes of a consultation, because work's done for you. The work after you leave will be typed up for you, so you get to see the interesting stuff. But if they're still knocking on your door for every patient, perhaps they're just, and particularly the things they're asking you, aren't rocket science. They're just sort of keeping on double checking things, which really they already know, or they have the resources to find themselves. That can be another telltale sign. The Beyond Blue study, about 25%. All right. The tactics. I'm also a chess player, so who knows what that little move is called, where you move the knight onto that square with the king and the rook there. Give you 4 seconds. No one else is a chess player or can't get to the thing long enough. 4 seconds. It's a winning move, shall it? Maybe not. Forking. Victor S has it. It is forking. It's not checkmate. No. Can move onto the square there. Anyway, enough about chess. It's a fork. You can fork with a pawn, catching 2 pieces, or fork with a knife there. Great game of chess. All right. Now, this is where you get another vote. Okay, so this is when you're uncertain, you have to teach the registrar. One of the things you teach them is your thinking time. And this is what thinking time. Are you an oral person? This is where you're not sure, and you have to say to the patient, I'm not sure. Do you stroke your chin wisely and babble? Do you flick through your notes for inspiration while your brain is actually trying to think what the hell's going on? Do you go for prolonged hand washing, or is it aphelia, I think, hand wringing? Do you do some action? So like, I don't know what the hell is going on. How about I give them a little test, you send them off for the urine test and get them back tomorrow, because by then I will have thought of something. This isn't a very serious vote, but just quickly stick down your votes as to your favourite little method of pretending you're smarter than you are and buying yourself a little time. Talk through it out loud. That's an oral thing. Think out loud. Think out loud. Is that oral? I don't know. All right. So visual. Flicking through the notes is the favourite. All right. I used to do the auscultatory thing. I'm not sure where that fits in, which is you just listen longer to bowel sounds while you're thinking, what on earth is causing this abdo pain? I didn't put that in as an option. Google, our friend Dr. Google. Very good. Thanks, guys. Now, the next one is this is Dr. Jared Ingham, who is a GP in Daylesford and also the bass player in my band, which is why I let him, I take his words of wisdom. He's got the 3 R's that he uses when he's not sure what to do. And one is review, and as Jared says, that's nearly always the best option. So the kid with a fever, that logical thing, the most common thing you would do there would be probably review, preferably the next morning for a young kid. Safety netting, get them back. And as Jared says, you've waited 2 weeks before seeing me thinking this condition would resolve. It has indeed improved a little while you waited an hour in my waiting room. I wish more patients were as clever as you, because it probably is one of those wait and see scenarios. Let's wait and see. That'll be $50, thanks. Bingo, you've got yourself a great consultation. So the other trick you can use is saying, I've been a GP for 25 years and this sort of thing just about always goes away. Your registrar can't use that one. All right, referring is sort of second best, I think, if you can't review. But the referring here doesn't necessarily mean to a specialist. It can be, for the registrar, it can be referring to you, so sort of heading upstairs for help, phone a friend, or in my own practice, I get a second opinion, once in a while, not all the time, but once in a while from one of the other doctors who's around, things like rashes and stuff like that, or just things I can't figure out what to do next. And the treatment, the third R is a cheat R, it's really a T. Could a trial of treatment help? And trial of treatment, you have to be careful with them, but, they talk about, the classic safest one is probably dermatology. If it's wet, dry it. If it's dry, wet it. And when in doubt, use steroids. The old adage works every time. Pretty safe. Slobber a cream over it and see what happens. But there's sort of, if you're not sure about wheeze and the person's had a bit of asthma in the past, you could send them home with a puffer and see if it helps. So, but they do have their disadvantages too. There's again the use of pharmaceuticals. So it's probably definitely a third line option. So ask the registrar. Of course, if you have a smart registrar, do that all the time. I've got this medical student at the moment actually who's very smart, and I've made 2 mistakes in front of him with drug names on yesterday, but that's another story. Very embarrassing. But anyway, luckily he knew I was the master of uncertainty, and I didn't feel all that bad because it's all a learning situation. What are the strategies for managing uncertainty? These are strategies. Okay, first of all, you do have to honestly accept uncertainty is inevitable. In fact, all of us do. We mightn't talk about it a lot much, but you look at any experienced GP, sit in with them, and unlike on TV shows or legal cases or whatever it is, or doctor jokes, uncertainty is inevitable. Sometimes the registrar is not asking the right questions and getting the data, not necessarily the data about the red flags, but the data about, for example, finding out the patient's situation, prescribing things for patients where they just aren't going to be able to afford it and they're not being sure why it didn't work. The identified patient's agenda. So, these two, and shared decision making, again, we keep coming back to it. Uncertain diagnoses, uncertainty is the key time you got to do this. Involve the patient. They'll let you know if they think it's absolutely unacceptable that you are not doing something, and you probably need to take that into account, because then you start getting into dangerous territory where things can go wrong, or you're more likely to get sued if they do go wrong. If you get that sensible, everyone loves that sensible mum, salt of the earth, she can get back in tomorrow, no worries, and you just know that, look, you send the kid home. If anything happens, she'll be off to the emergency department or back to you. It's just a much safer situation, but you've got to find out more about the patient's situation. We know the patients much better than our registrars. Reason analytically speaks for itself, and again, trying to avoid some of those cognitive biases, seeking evidence that may be a test which the registrar hasn't thought of, maybe a simple on-the-spot test the registrar hasn't thought of. And safety netting, which has come up time and time again. So for all these things, safety netting is very important. And then we're going to finish off on you're teaching the skills. So this is sort of methods of teaching your registrar. So again, I refer you back to the document, and these headings are there, but I'll run through them in about the next 2 minutes. Clearly, I'm teaching you about uncertainty. Now you are the uncertainty master. You teach your registrar about uncertainty. So I think it's worth a specific tute on it. I think it's a great tute. Not when they first hit your doorstep. There's many more important things to teach them about, but I reckon that term one, that the second half of their term one, it's a good one of those meta tutes, talking about what is general practice, why do we make the decisions we do. I think it's a fantastic tute, which you both can get a lot out of. Fostering tolerance of uncertainty. You cannot, despite what the newspapers tell you, or Dr. House tells you on television, or your really super smart, brother-in-law, super specialist at a family barbecue tells you, you cannot aim to be sure the whole time. Trying to be sure involves way too much intervention. You cannot chest x-ray everyone who might have a 0.01% chance of having TB. We know all this. Registrars need to be taught it explicitly. It's a good reason why we don't just do super numbers of tests on everyone. Good scientists are always uncertain, says Terrace. That was sort of my quote from my thing I read out before. Use consultation analysis. So this is that sort of random case analysis. Again, I think people like Simon Morgan and indeed Jared Ingham talk about that sort of stuff. So you sitting in with Sally and analysing that, the point of that is you don't just tell Sally, this is what I would have done in that situation. I wouldn't have done that blood test and I would have gotten them back there tomorrow. You analyse her consultation. Why did she do it? And get her to reflect herself. Is it because of uncertainty? Clinical reason, decision-making skills, again, sort of self-evident. Role modelling, that's why you guys are here. You are the role models of the people who will look after us when we get old. And realistically, if you are the type of person who says to her, I don't use these tests, and you order huge tests on everyone, clearly it's not going to work. And again, I talked right at the start about the experience registrars get in your practice. That is the type of doctor they are more likely to become, by role modelling you. It's a bit like ducklings, something about ducklings. Support evidence-based practice, and there you need your resources. So, and in fact, I find actually all the ones coming through actually already good at this, I reckon. Maybe there are exceptions, but, they all have their up-to-date and their therapeutic guidelines and all that sort of stuff. We have another highlighted one here from Michael F. There is always certainty underlying uncertainty. I like where this is going. I've no idea where it's going, but it's a good start. I'm sure it's safe to watch and wait 4 hours, and these are the specifics to watch out for. Typed a bit fast, Michael, a couple of typos there, but I get what you mean. So it's sort of that I've been a GP for 25 years and I've faced this a lot sort of scenario. The thing is, there's a lot of consultations we do every day where we can be certain that if our peer was looking at it, they would also think that is a reasonable approach. I think that's probably what Michael's saying. So you don't need to be 100% certain of the diagnosis, but that doesn't mean you can't be confident that you've done the right thing, done a good job. And that registrars, of course, don't have that confidence, and it's up to us to tell them. It's often a good thing. I think I've finished actually, which is scary. I think I really did talk too fast. So do I have any last words of wisdom? No, I think really, Shelley, thank God you're back on. Say something. And how did you enjoy that, Shelley, since you got the microphone?
It was fantastic, thank you. So I actually wanted to thank you for tonight's webinar on managing uncertainty. Thanks for the great resources, the great references, the fantastic dad jokes. You know, I've written them down to share with my own children at a later date. But fantastic. So anything else you wanted to add, Justin, before we finish up?
No, I just would be delighted if we, that first thing I said, which was, I think I got it from an article, that the managing uncertainty is the specialty of general practice. I really think there's a lot to that. That's why at barbecues, we are actually pretty good, despite the, specialist brother-in-law telling us how much he earns. Once, a few kids start running up with their rashes or their sore fingers, or Uncle Bob shows you his boil. I mean, we are good at that sort of stuff, and I think we can handle that better than, because we do it in 15-minute increments our whole career. We have no idea what the person's going to walk in with. So I think it's we specialise in something very special. So let's teach about it explicitly. Great. Can I read Peter B's quote to finish? If a man will begin with certainties, he shall end in
So everybody,
doubts.
we'd really love your feedback on tonight's webinar. I've actually sent you all an email with a link to the feedback document. Included in the email is a copy of Justin's presentation this evening, as well as the link to our next webinar, which is on blurred lines, mandatory reporting of colleagues, which is taking place on Thursday, the 18th of May. So just before we finish, I'd just like to acknowledge that GPA is supported by funding from the Australian Government under the Australian General Practice Training Program. And thanks again, Justin. Have a great night, everybody. Thanks for joining us.
My pleasure. Thank you, Shelley. And that's a little plug for a podcast, GP Skeptics, where we discuss stuff like this all the time. It's Liz Sturgis and I, another GP, do it. So go to iTunes or wherever you get podcasts, or Google GP Skeptics, and you can listen to me rabbit on again about other topics. Thanks.
Thank you.